Good afternoon, and thank you very much for joining us at this technical briefing on investing in jobs here at the 72nd session of the World Health Assembly. I'm James Chau, the WHO Goodwill Ambassador for SDGs and Health. We're delighted that you can be with us and that we can be joined by such distinguished visionaries on this panel and around this panel who I hope and we hope are going to bring a new momentum to the health workforce as we envision it in this century. Investing in the health and social workforce is critical, obviously, to the attainment of the SDGs, but the WHO projects a shortfall of 18 million health workers to achieve and sustain universal health coverage by 2030, particularly in low and low middle income countries. The largest share of the investment required to achieve UHC by 2030 is for the education and employment of health personnel. So those are some of the thoughts that we can keep in mind going into this time together. Quick reminder also that we're joined by a global audience on live stream, on social media, and also this session will be in different languages and there will be simultaneous interpretation in the 6 official UN languages. A very special welcome to our guest, to Madam President Ellen Johnson Sirleaf, who, as we all know, is the former president of Liberia, the first elected female head of state in Africa, a Nobel Peace Prize winner, and as of, I think, just a couple of minutes ago, the newest World Health Organization Goodwill Ambassador. It gives me great pleasure to welcome the Director General, Dr Tedros Adhanom Ghebreyesus, who will formally welcome Madam President.
Your Excellency, President Sirleaf, Excellencies, Ministers, Excellencies, Heads of Delegation, colleagues and friends. Welcome to this technical briefing on this vitally important issue. There is no health without health workers. Health workers are there at the first moments of life and in the last. But currently, the world needs 18 million health workers more by 2030 to achieve and sustain universal health coverage. That's the challenge we all face. This shortfall will be felt most acutely in low and middle income countries. As you know, closing that gap takes commitment and investment, and it takes champions, which is why it's my great honor and privilege to introduce WHO's new Goodwill Ambassador for the health workforce, the former President of Liberia, Ms. Ellen Johnson Sirleaf. Such a great honor to have you. And in my remarks to the Assembly on Monday, I spoke about the 3 priorities that must guide our discussions this week and throughout the next year: political leadership, partnership, and people. Her Excellency personifies each of these priorities. She was the first elected female head of state in Africa. She provided political leadership throughout her mandate, notably overseeing Liberia's response to the Ebola outbreak in 2014-2015, if I talk about the health aspect only. She built partnerships in cabinet and the international community to oversee the expansion of primary health care and universal health coverage. And she has invested in people, both the people who have a right to health and the health workers who are the foundation of health for all. As a former head of state, a former minister of finance, she knows how to make things happen in government. Her personal commitment to empowering women and young people makes her perfectly suited to this role as WHO Goodwill Ambassador to Health Workforce. And we're fortunate that she accepted the challenge. Your Excellency, my personal thanks to you for accepting this appointment. And I would like to express my greatest respect and appreciation on behalf of WHO. I invite you to make your remarks on investing in jobs. Madam President.
Great. Thank you, Dr. Tedros, and it's very pleased to see you here as the Special Representative to Secretary General on SDG for Health, and to see all the many persons in this room. I'm told that after making remarks, there are many others that will be talking, and I'd like to listen to them because they are those who really know what's happening in the issue of creating of jobs and being able to promote health systems enhancement all over the world. So we all will be listening to them, and I believe it's going to be quite an open and active session in which others will have the opportunity, if there's time, to be able to talk about some of their rich experiences and what they've been done to encourage the promotion of job creation in all our countries. It is always a challenge for the allocation of public resources by those who are charged with the responsibility for this, whether it's a finance minister or president. When you have all the many competing needs that have to be addressed. In our Liberia case, where you are concerned with the total reconstruction of a devastated country, and where you have to be able to allocate resources to fix, to promote, to reconstruct in every area of society's endeavor, that makes it very difficult. But we also knew the importance of health system. We knew that because we lost a lot of our health professionals and health workers because of the time of conflict, that it had to receive some emphasis. The majority of the workforce in the overall national capacity of the country come from two sectors, the education sector and the health sector. And they are the ones who most times are marginalized, most times are not the one that get the full support that's required to enable them to carry out their duties effectively. And so in our case, the first instance was to look at the fact that we didn't have enough doctors to serve our hospitals. And even though we were allocating resources for the physical reconstruction of clinics and hospitals, but we also knew that if you did not have the persons to actually go in and manage those facilities, it would have just become a white elephant. You just have a building sitting there and not being able to really address the needs of the people. And so being able, first of all, after trying to reconstruct buildings and clinics, ensuring that we had programs to get our medical schools reactivated, attracting young people to go into training and providing them the subsidy that was required for that, looking into our rural areas where there are not many facilities anyway because of the deficiency in infrastructure. How do you ensure that at least you have enough of them assigned to those places where they can be reached so that we could promote our primary health care, which was part of our national goal as an immediate step to restoring health to our people. And so we then knew that the nurses, we had a nurses training school that again had become dysfunctional. And so we had to do resources to start training nurses again and be able to get them into the field. And the importance of putting money into those areas is that it has a multiplier effect. Once you get the health workers and you get them paid and you get them moving, they are then able to inspire the community to do other things. The resources that they make, by them being paid, enable them not only to do for their family, but because of the nature of the service they render, they tend to reach out and they tend to do more in the community they tend to provide more assistance and more support to communities. And so we had to do this, and I'm just, as we moved along and our health system began to improve as a result of the allocation of resources, we also had the opportunity to look beyond that and see what can be done. Midwifery, our pregnant women who could not get to hospitals because of the lack of it. The only thing one had to do was to provide support and training for those midwives who could be able to get to them very quickly in a place. We never had enough resources to be able to put what was required to meet the need of ensuring that we had a health system that was totally responsive to the needs of the people, that could rebuild and that could ensure that every one of our citizens had access. No, we never had those kinds of resources. But that is the goal, and that's what we have to focus on, that this is a goal, because to create those jobs, what enables a community to become functional, enable them to start economic activities that can spread throughout the community. And so I know that let me point to Dr. Tedros and the fact that in Ethiopia, he's the one who blazed the path based on the very, we all know the visionary Prime Minister, and how he was able to move that system. I think we even have in our room our own health minister, Dr. Jala. She may be somewhere in here. I saw her earlier, but I know that she's been able to also rise to the challenge and to build upon what we have done to spread a bit more with additional resources that may be there to be able to create those jobs in the healthcare system. And when in training them, training them also, we're not also talking about workers, the nurses and the practitioners and the health assistants and all of that. We're also talking about professionals. And we're talking about the healthcare associations and what they bring to this task, how they can be given the support. So they become the ones that are going to tell the story. They're the ones that talk about what are the effects of creating those jobs in the healthcare system. But I know from our experience and what we were able to achieve to ensure that primary health care provided the help so that people in communities could once again feel like they were able to work. They were able to do for their families. They were able to make contribution to our overall economic goals. And that's what, in creating those jobs in the healthcare system, there are very few other areas that have so many people. And who are the main workers? Who are the main beneficiaries? Who are the main promoters? Women. Women and youth. Healthcare system, what you see are those brave women taking risk, providing care, showing compassion in what they do for people. And more recently, with our countries being so young, being able to extend jobs, paid jobs, to youth who can take the responsibility to carry out, to become those first responders in the community, is something that's going to have a major impact to improve the healthcare system, not only in my country, but I'm sure all over the world. Thank you, Dr. Tedros. Thank you.
Thank you.
Thank you very much to Madam President for reminding us of where the focus should be, where the opportunities are, and what can become a reality in the future if we work towards that. You are an example of everything that is possible. Dr. Tedros, may I ask you to add some comments, please?
Yeah, thank you, Your Excellency. Again, thank you so much indeed. That's very enlightening. Excellencies, ministers, heads of delegation, ladies and gentlemen, I would like to follow Her Excellency's remarks with 3 personal reflections on people and investing in jobs. First, investing in health sector jobs is not a matter for health ministers alone. It's a matter for Ministry of Education, Employment and Finance, working together to assess needs, design solutions, and fund those solutions. It also takes cooperation between sectors at the global level. I'm personally engaged with Angel Guerra at the Organization for Economic Cooperation and Development and Guy Ryder and his team at the International Labour Organization to ensure a common approach to improving employment, health, and economic growth. This partnership between WHO, ILO, and OECD takes forward the Working for Health program adopted by the World Health Assembly 2 years ago. Mr. Musa Omaru, Deputy Director General of the ILO, is with us here today, and we really appreciate that. And investing in jobs is a must for primary health care and universal health coverage. I extend my thanks to Member States for adopting the resolutions yesterday on primary health care and the role of community health workers. Statement after statement highlighted that we need to urgently invest in health workers now. The second point I would like to make is that the health workforce is a team. Allied health workers, community health workers, doctors, dentists, lab technicians, midwives, nurses, pharmacists, and many other specialist occupations, they all have a role to play. Delivering high-quality care takes teamwork on the ground, and it takes teamwork at the international level. Earlier this year, I met with both the President and the Chief Executive Officer of the International Pharmaceutical Federation, FIP, which is the current chair of the CEOs of the World Health Professionals Alliance. This morning, we signed a memorandum of understanding to work together to engage all professional associations and health worker organizations. You will hear more about the progress we have made and the call to action we're issuing in the next panel from my friend Catherine Dogan. In the past year, WHO has also strengthened its partnership with the World Medical Association, WONCA, the Organization of Family Doctors, the International Council of Nurses, and the Nursing Now campaign, the International Confederation of Midwives, the Royal College of General Practitioners, IFPMA, and others. Thank you all for your partnership and for the productive discussions we had in the past few months that led to this briefing session today. My third point is that investing in jobs is an investment in women and youth. And that is what Her Excellency, the President, just said, and I fully agree. And globally, 70% of health workforce are women. But while women contribute $3 trillion annually to global health, half of that is in the form of unpaid care work. Expanding the health workforce will offer tangible opportunities for decent work, gender equity, and women's economic empowerment. But to realize those gains, we can and must do more to address the gender differences in the health workforce. If we do that, an investment in the health sector can truly be an investment in gender equity. It's also an investment in youth. In recent decades, the health and social sector has become the biggest employer of young people, and employment rates have risen faster for young people in this sector than any other age group. This trend is reflected in nearly every country, regardless of income level. You will hear more from Dr. Kalin Matar on how WHO is supporting your engagement and leadership through the Youth Hub. Excellencies, ladies and gentlemen, As I said on Monday, the ultimate measure of whether our work this week is successful is not whether we approve resolutions, or not. The ultimate measure is whether those resolutions are translated into laws, policies, plans, and programs that make a difference on the ground. To our colleagues in Ministries of Health, I ask how you will work with your colleagues across government to invest in jobs. And to our friends from professional associations, I don't want to go into details, but I expect the commitment from all sides to take our agreement into action. And I call on all of us to join forces across professions to move together instead of in parallel. Invest in jobs for UHC, ensure decent work and eliminate discrimination, implement what works, activate the power of youth, and harness technology to maximize impact. For our part, WHO is committed to generating the evidence and tools to enable countries to make smart investments that pay long-term dividends. So I assure you of our commitment, and I wish us successful deliberation. Thank you very much. And finally, I would like to again express my greatest respect and appreciation to Her Excellency President Sirleaf for accepting the challenge, the major pillar of the universal health coverage, the workforce, because UHC will not happen or will not be realized without workforce, never. So it's a big challenge, and thank you so much.
Thank you very much to Dr. Tedros. And I think that, together with Madam President, beautifully sets the scene for what will be an exciting session coming up as well. May we invite the panelists to join us now on the podium. We have Peter Salameh, Björn Inge Larsen, Musa Umaru, Catherine Duggan, Colleen Mata, and also Joseph Kabore. So with the speeches out of the way, but the vision firmly set, now we get down to the second round of business, which is this panel debate. We want to make it interactive, exciting, and dynamic, but also inclusive, because the workforce is all of us. So what we're going to do is that we're going to have Peter Salameh set the scene for us. We're going to go then to borrow and leverage the insights of our panelists here. But I think at certain points, I'm going to try and come into the audience, not just for your planned intervention, that will be separate, but if time allows, maybe some spontaneous feedback so that we can keep the momentum really going over here. And as we said, Peter, you'll be starting in all the panelists. You have an enormous challenge ahead of you, not because I said it's going to be exciting, but because President Johnson Sirleaf said it's going to be exciting and active. So we're going to start off with Dr. Peter Salameh, who is a medical epidemiologist from Australia. He is the new Executive Director for Universal Health Coverage and Life Course here at WHO. Congratulations, Peter. Peter brings with him extensive experience in managing emergencies. He was the head of the Health Emergencies Program for 3 years here at headquarters at WHO in Geneva. And before that, he led UNICEF's global response to Ebola. So, Dr. Peter Salameh, let's start with you.
Thank you so much, James, and warm welcome to what is quite a critical session, in my view, for this World Health Assembly. I want to just do two things in my opening statement. I want to make the linkages between the theme of WHA this year, UHC and PHC, and why the health workforce is so critical to that discussion. And then I want to make a few linkages between the economic arguments, the jobs arguments, and the health outcomes. So firstly, on the UHC-PHC agenda, if we're going to succeed in getting those extra 1 billion people access to universal health care, then it's very clear we have to have a skilled, trained, capable, stable workforce. And while that's an issue for all countries, and it really is, in all of my bilateral discussions with health ministers this week, it doesn't matter if they come from high-income, middle-income or low-income countries, they all have issues to raise related to their health workforce. So it's a global issue on one hand, and yet it's also an issue of inequity, because we also know that the places with the highest disease burden have the lowest density of qualified health workers. So it's both a global issue, but an issue of massive inequities. We've also reflected this week on primary health care and the new challenges that primary health care and the analysis of global disease burden brings. And that has real implications for our health workforce, and we need to consider those in this session. For example, many countries spoke about their epidemiological transition. Rwanda talked about having a triple burden: NCDs, communicable diseases, emerging infections, emerging issues. So the health workforce is now challenged to do much more at the same time as they're being put under pressure in terms of budget. We also have discussed the fact that we need to deal with people across the life course, which includes opportunities to reach not only young children, but adolescents. It also includes the issues of an aging population. Geographically, our focus is increasingly going to be on the urban poor, who will number shortly 2 billion people. How are we set up in terms of our health workforce to deal with those 2 billion urban poor? And what about the countries that actually did least well in the MDG period, the fragile states? What does the health workforce look like in fragile countries? And finally, the issues of quality. They've come up again and again this week. If the MDGs left out one thematic area, it was probably the issue of quality. And isn't the health workforce absolutely intrinsic to addressing those quality concerns that so many countries are raising? What does all this mean? It means that beyond the technical discussion, as we think about supporting countries and as we think about systematically assessing their disease burden, linking that to the service delivery package and tailoring our solutions to each individual country, we're going to need one particular cadre of worker more than any other perhaps, and it's the health workforce planners. A critical set of skills that's going to have to adapt all of those technical discussions and make the implications clear for the workforce. And for some countries, the solution may be a massive increase in community health workforce. In others, it may be more family doctors. And there may be different solutions for many different other typologies. My second point, James, is on the investment and what that means to link the health discussion with the economic discussion. We've talked about the potential to generate jobs and advancing inclusive economic growth. But beyond that, we're also talking about the implications for human capital. To set up a virtuous cycle, we talked about how the fact that investment in health workforce is a pro-woman investment, with 70% of the workforce being women. But beyond that, we can think about the downstream implications of the fact that women, of course, are more likely to invest their own salaries into the families, into education, into food, into basic needs. That has implications also for further healthier populations, which in turn creates a potentially virtuous cycle of increased productivity as health outcomes improve, which has even intergenerational implications for families. So this is a very complex, virtuous cycle that we could set up, which would really be a multiplying effect. But unfortunately, we don't live in a perfect market for healthcare, and there are many market failures. Not least is the fact that we are going to generate in the next 10 years more and more jobs in the health workforce, but they're going to be predominantly in high-income and upper-middle-income countries. And where will the gap be? Of those 18 million health workers, they will be in lower income and lower middle income countries. So the global market will fail us if we allow it to. And that's where we need to step in. And what do we have to do? And I'd be really interested to hear, James, from our panel, in order to correct those market failures and this complex set of demand and supply factors. Finally, and it's great to have Madam President here, who, as you know, has an extremely deep expertise, not only as a head of state, but in financial matters, to really advocate for the issues around recurrent budgets, for health and finance ministers understanding that this is not just about recurrent costs, but about a true investment in societies, and also the complex arguments to create much more macroeconomic arguments for broader fiscal space so that there are more jobs and more funded positions for health workers globally. Thank you very much, James.
Thank you very much, Dr. Salameh, for very thoroughly breaking down and explaining some of the key issues at stake and building onto what Madam President brought up. I mean, she opened up with talking about the challenge to public resources and acknowledging the competing needs, but also, and I think this is where you share a common strand, the reality of outbreaks, emergencies, but also the other times beyond that as well. So let's go into our panel. We're asking you for comments of about a minute or two, but I've also asked you to speak to each other, respond to one another, agree and hopefully disagree a little bit, and then we'll be able to build a narrative out of that. So let's start with Norway, with Dr. Bjørn Inge Larsen, who is the Secretary General of the Norwegian Ministry of Health and Care Services. And when we look at Norway as a whole, we look at it as the first member state to commit to implementing the Working for Health program. Dr. Larsen, why is this important particularly for your country? And if you could build a little bit around that as well.
Well, thank you, James. And I guess Norway is one of those countries where we do have sufficient health workforce, well qualified, but we have a very high willingness to invest in health. And we're all the time creating more jobs in our health sector. I think currently 11% of all jobs in Norway are in the health sector. We're using 17% of the youth to go into that sector, and still we have influx. And looking forward, we have an aging population, and we will create even more jobs. So our reflection was that we were actually going to be attracting a lot of workforce unless we have some real focus on this area, and that will be an undue burden on countries that have less workforce already than we have. So, so that is why we actually started interesting ourselves for this, because we needed to have a more conscious policy in our country to deal with our own challenges and not be a burden on others. And then we worked with the World Health Organization nearly 10 years ago, going into the global code of practice on recruitment. And then we have been continuous. Our minister has been on the UN high-level commission on investing in health workforce. So we've been following up on this and also financing some of the work internationally.
Thank you very much. Let's go now to Catherine Duggan, who's the CEO of the International Pharmaceutical Federation. So I think, Catherine, if I'm right, you're representing about 4 million pharmacists and I think millions more students. So you heard Dr. Larsen there talking about youth. You've heard Madam President talking about youth and women being key to the building of a workforce for the global future. Are we seeing that from your sector? And if not, how can we draw out more of that talent and skill that's obviously there?
Thank you very much, James. Thank you, panel. Yes, I am here in my role as CEO of FIP, but also as working in alliance with other health professions across dentistry, medicine, nursing and physical therapies. In pharmacy, we have a very high proportion of women in the workforce, and we have great programs of advancement, generally speaking, but we see it's patchy, and we also see the rise to leadership positions perhaps not as equitable as we might like. And I think this is reflected in many of the other health professions as well. I think reflecting upon this and how we can mobilise our health profession to seek leadership roles, even if this is at a lower level, is going to be really important and something that the Alliance can focus on. We have made quite a few commitments in the last week and about how the Alliance and partnerships can build and grow and flourish. And I have to say, building on Peter's point there about quality and investment, if you seek to strengthen the health system, this will actually help all of our professions play their right part in universal health coverage, and the investment in health professions will lead to the investment in health workers. We definitely don't want to put ourselves in parallel, as Tedros said. We need to work in alliance, and I think WHPA and FIP are committed to that. More later.
Okay, Catherine, I'm going to come back to you with more of your other thoughts. Let's cross over to Dr. Colleen Matta, who is the chair of the Youth Hub for the Global Health Workforce Network. I've got a couple of numbers for you here. We've got 80 million shortage, which we've all heard about a couple of times today. But secondly, we also have 1.8 billion youth. What are the thoughts around these numbers? I mean, can we somehow transform this and leverage this?
Thank you very much, James. So absolutely reflecting on the figure that you just stated, but also the aging workforce in the countries that are the hardest hit by the shortage, in addition to the transforming healthcare landscape. The short answer is absolutely youth is going to be the constituency that is going to fill this shortage. But there's a big however now. It is very easy to say, let's invest in jobs for youth and women. But it's easier said than done. We do need jobs which will allow youth and women to enter the health workforce, but also remain. We do see early attrition rates that are as high as 7%, and I'm going to tell you why. Maybe I'll start with a question to the audience here and ask you, if you in your job face violence, gender discrimination, coercion on a regular basis, would you stay in your job? That's unfortunately a reality for many young people around the world. And I will take this chance to address the higher-ups in the health workforce here and also the educators. We will be launching tonight a draft report from the Youth Hub regarding the evidence around decent work in the health and social sector. We see that bullying and harassment, the numbers are particularly staggering and they're actually quite scary. And while all of you right now are thinking that it's the evil senior doctors bullying everybody else, unfortunately, every single profession is the culprit. Senior doctors bully junior doctors, senior nurses bully young nurses, senior nurses bully young doctors, and I can keep going on and on and on. So I would like to ask you today, when you go home, to help us stop this pervasive culture in the health sector and help us invest in jobs that will actually give women and young people the dignity they deserve to work. And one last comment, as the Youth Hub, we are a group of organizations from different health professions, young professionals and students. We have come together to commit that by 2020, we will actually equip young people at the national and local level with the skills they need to advocate for evidence-based policy around decent work. And in addition to that, we will fill the evidence gap on health and the social sector as far as youth employment. So I encourage you all to take a look at our report and to continue engaging with us. Thank you.
Okay, let's have an answer to that question you put out there. And maybe we can slightly reframe it. Instead of saying, if you face discrimination, whether it be gender or violence or other inequities, would you stay in your job? I don't think any of us would choose to stay in our job, but maybe we can have a show of hands here. Are you in a position in your current role to stay in your job for financial reasons or other reasons if you face discrimination? Who would be able to leave their job under those circumstances? We've got one, I mean, be brave about it. I mean, the camera can't see all of you, it's just us. I mean, not many, so a minority of people here say they're actually in a position to be able to leave their job, and I suppose most of us are very, very privileged to be here at the Palais in the first time. I just quick feedback, I mean, Rupert Dutt, you're with Women in Global Health over here. Since we're talking about gender, and we just heard there from Dr. Matta, all these different permutations of bullying. So it's not just one direction, but it's multi-directions. What are your experiences in representing women in global health today? And as a young woman, but a very highly skilled one as well.
Thanks, James. Dr. Matta really captured it quite well. It's quite pervasive. So the bullying culture applies and is across genders. And so particularly when Women in Global Health, we talk about gender equality as everybody's business. It applies to all genders. So that culture of bullying is regardless happening all across the health sector. Some astonishing numbers are legislatively, there are still 100 countries that don't actually make it a penalty to have sexual harassment in the workplace. So when we think about solutions addressing addressing harassment, bullying, we also need to think about the laws that we're going to be changing to really create decent work. So that's at least one perspective coming out of the Gender Equity Hub and from Women in Global Health.
Thanks for your insight on that. And a very quick word, yesterday we had a technical briefing on mental health, and someone tweeted afterwards, and I think it was a very fair point, that we went through a 2-hour session or near 2-hour session, and there was nothing said about mental health for the health workers as well. So it's not that we were missing that out on purpose, but I think today is very important to continue looking to the comments that you've been making, not to be afraid of them, and to bring them back into this discussion. I think Thursday with this technical briefing on the health workforce, that's very present as well. May we cross over to the ILO, and we're delighted to be joined by Musa Umaru, who's the Deputy Director General for Field Operations and Partnerships for the International Labour Organization. I believe Mr. Umaru will be speaking in French. Mr. Umaru, I mean, a couple of questions, but I suppose the first one to tie up how Norway began here. ILO is a member of the Working for Health program. What can you tell us in terms of your thoughts and how the organization can support addressing this huge, gaping 18 million people shortfall?
Merci beaucoup, mais avant de répondre à votre question, je voudrais saluer la présidente qui est à nos côtés ici et lui dire tout mon respect et toute mon admiration pour ce qu'elle a eu à faire, non seulement pour son pays, mais pour l'Afrique et pour la communauté internationale d'une manière générale. C'est ce que je veux dire. Alors, pour répondre à votre question, je veux dire qu'au niveau de l'Organisation internationale du travail, nous nous intéressons beaucoup à ce sujet, et particulièrement au secteur de la santé, par son importance. Peut-être que pour parler de l'importance de ce secteur, c'est de donner quelques chiffres. C'est que selon nos estimations aujourd'hui, il y a 130 millions de personnes d'emplois qu'il y a dans le secteur de la santé et que cela représente 3,9% des emplois qu'il y a dans le monde. Autrement dit, c'est que nos estimations nous permettent de dire qu'il y a un potentiel aussi de 130 millions d'emplois qui peuvent être créés. Parce que pour chaque emploi direct, si je puis dire, qui est créé dans le secteur de la santé, il y a deux emplois indirects. Donc, ceci, c'est d'abord une première source d'emploi et d'intérêt pour nous. La deuxième chose que je voudrais dire, c'est que c'est un secteur qui est aussi pourvoyeur d'emplois, notamment pour certaines populations, notamment les jeunes et les femmes. Je reviendrai plus tard sur cette question-là. Et troisièmement, c'est que l'investissement dans le secteur de la santé, c'est un investissement qui est porteur de croissance économique tant au niveau national qu'au niveau global. Alors, pourquoi cet intérêt au-delà de ces chiffres? C'est que ce secteur aussi connaît comme d'autres, peut-être dans une moindre mesure, un déficit de travail décent. Un déficit de travail décent dans la mesure où les conditions de travail, la pression sur le personnel de la santé sont si fortes que les horaires et les heures de travail sont immenses. Et la deuxième chose que je voudrais dire, c'est que c'est aussi un secteur qui aujourd'hui connaît une discrimination en matière salariale, notamment pour le personnel féminin qui est là. Et une des pancartes qui est juste derrière moi ici parle de ça, et à juste titre, l'importance qu'il y a à assurer la non-discrimination en matière, en tout cas, d'emploi et de rémunération pour tout le personnel qui est là. Et autre chose aussi, c'est que c'est un personnel où cette pression fait que, au-delà, si vous voulez, de l'emploi qui est créé, au-delà du nombre de personnes qu'il faut avoir dans le secteur, le plus important, c'est de créer les conditions pour que les gens puissent rester, d'abord accéder au secteur et y rester. Et assurer aussi, pour ces personnes qui sont restées, des conditions décentes de travail, que ce soit au niveau des horaires de travail, que ce soit au niveau de la rémunération, que ce soit en matière de perspective de salaire et de carrière, pardon. Donc voilà pourquoi ce secteur-là nous intéresse au plus haut point. Et c'est un secteur aussi qui, disons, connaît de grandes mutations. Et ces mutations sont liées aux mutations que nous connaissons aujourd'hui dans le monde, qui sont liées à la fois à la question démographique, qui sont liées à la question technologique, qui sont liées à la question environnementale. Et tout ceci fait qu'il y a si vous voulez, des grands changements qui sont en train de s'opérer dans le secteur de la santé. Et comme nous sommes aujourd'hui à l'Organisation internationale du travail en train de fêter et de célébrer le centenaire de notre organisation, nous sommes en train de penser à ce que devait être l'avenir du travail. Quel avenir du travail pour le secteur de la santé, comme les autres secteurs? Nous sommes aujourd'hui à ce niveau de réflexion. Et un des points importants, c'est ce qui est sur le panneau, qui est juste à ma droite, donc à la gauche de ceux qui sont dans la salle, c'est de centrer l'avenir du travail dans le secteur de la santé, comme les autres secteurs, sur l'humain. Donc si on dit l'humain, c'est d'abord le personnel de santé et les gens que les personnels de santé ont à la charge. Et cet avenir, on ne peut pas le faire, on ne peut pas le centrer sur l'humain si on ne pense pas à la mise en œuvre de processus et de dispositifs pour un apprentissage tout au long de la vie pour gérer la transition que nous connaissons aujourd'hui.
Thank you very much, Mr. Umaru. Dr. Duggan, I'm going to come back to you because it makes me think again about this 18 million health worker shortfall. And I think, well, we're here in the Palais, but I think you went to a chateau on Tuesday night where you worked for a couple of hours with presidents and CEOs of health groups. What were the issues that were raised and what were the commitments? If you could summarize the spirit over there, and was it optimistic, or were they meeting because you told them to meet?
Well, turning on the volume. Thank you, James. I think the opportunity to meet in a separate environment where everybody is able to interact affords an opportunity to be more optimistic. I think when we look at the shortfall, it feels unmanageable, especially as our populations may be ageing and our workforce may be suffering attrition. The gap seems to be widening. So it does seem an unsurmountable hurdle, but the mood was optimistic and there were some very concrete outcomes. Now, I just take a moment to give 3 reflections from my perspective and that of the Alliance as well as pharmacy within that. And using Tedros's, the 3 Ps, partnership, political leadership and people, I think the Alliance itself is a partnership and we need to amplify more about what we're doing across the health professions. And we understand that if we can strengthen the health system to do that, we're going to be able to bring the health workers with us. The second thing around partnership was interprofessional collaboration. Very much from that perspective, it's paramount to break down stereotypes and misconceptions, and I think Tedros mentioned it. If we continue to work in parallel, then we're not going to achieve that additional benefit. We're greater than the sum of our parts, as it were. And the Alliance agrees that it's crucial that we're at the table whenever workforce is discussed. Really pushing forward the idea you can rely on the WHPA when seeking advice and assistance. One thing we felt as an Alliance was that health workforce itself needs a vision to get behind. We understand as health professionals our place within delivering primary health care and thus achieving universal health care. And we struggle with that ourselves. But we need to mobilise our community workers and our health workers collectively with objectives that they can see are concrete and deliverable. And we need to do that through political leadership with a little p. Each of us can be political and with a big P. And I think that kind of summarises where we want to get to with the delivery of primary health care and bridging the workforce gap. I've got more to say, but at another point.
Oh, okay, because I've got another question for you. You talk about interprofessional. I was just wondering, I mean, I know that we're here in Geneva and you're probably doing other things as well, but don't we need to be outer-professional? Don't we need to engage people way outside of the sector? Because if you're talking about health organizations, one assumes, especially since you said they're all optimistic, that we're sort of spreading the message within the positive choir over here. Do we need to go far and beyond and be a lot braver, maybe speaking to the people around financing or in civil society, in youth groups, in women's groups, in so much further and beyond what appears to be on paper?
Yeah, I'll take that challenge absolutely on the chin. I think the thing is we need to do both. We can't wait for all of the finance leaders, all of the civil societies, all of our women's groups and youth groups to be mobilised. We need to also mobilise ourselves and step up to the challenge as professionals. And accept that where one profession may be working, like community pharmacy may be found in certain countries, they can afford access to care. What about empowering the community pharmacist at that point to work with the women in the community to enable responsible use of medicines? What about making that part of the pharmacist's work and then not having a barrier between them and the doctors, the dentists, and the physical therapists and nurses around? So I would say, James, that you're quite right. It's like speaking to the converted. But we all know that in the privileged positions of health professions, we can still have our silos and want to hold on to the roles that we've always held. So I would say, I would build on Tedros's point, which is we need to make some quantum change. We can't work in parallel, but you can't do it separately. Everybody has to make that movement towards. So in summary, yes, we need to work interprofessionally and out-of-professionally, and we need to all do it now.
You know, I think we're hearing some great ideas from our speakers up on the podium, but I wonder whether anybody here in the audience, because we're all in this room as peers, as allies, does anybody else have a solution or an idea or a comment? Are we missing something so far? Is there a particular segment? I mean, I can see Rupert nodding away, but I'm going to ask somebody else this time. The delegate in the middle, I mean, you're nodding. What are we missing?
So my name is Nadia Cobb. I'm with the University of Utah. I'm a physician assistant. And I've been working a lot with kind of the middle level clinicians. But I think what we're missing in a large part of a lot of the programs that I've gone to, although very stimulating and excellent, I've not heard a lot about education. And I think one of the challenges I see is that until we start training the health worker teams as true teams, instead of the manner in which we've always been trained, we won't expect the future professionals to be able to continue in a new way. So I think it has to come from both sides. But I think education is absolutely the core of all of these discussions. Thank you.
Okay, another idea at the back, please.
Vanessa Kerry from Seed Global Health, and I want to really echo that because investing in the healthcare workforce, including all health professionals and across the continuum of service delivery, is going to be key to eliminating the two standards of care that exist in the world. And this investment will ensure that there's a pipeline of health workers who can deliver quality care, but also provide ongoing education both across generations and across the health workforce, help problem solve, and ensure that health systems are not ravaged by health crises, but can respond to and even prevent them. I want to say thank you to Madam President, because I think your words and experience and willingness to highlight what happened in West Africa and then to emerge from that epidemic to really highlight the importance of your health workforce is critically important. If you think about it, there was a single patient that was sick, and a lack of health professionals and infrastructure led to $53 billion in economic decline. Epidemic that crossed six countries, 3 continents, over 28,000 cases, over 11,000 deaths, and 230 healthcare worker lives lost. But the disruption of those health services led to even more lives. It's projected that measles, actually, there were more deaths from measles from the disruption of services than may have happened projected from Ebola itself. So health workers, including health professionals, are essential. We've made many meaningful interventions in health throughout the years, but we've never really fulfilled our full promise because we've never fully and deeply enough invested in comprehensive healthcare workforce. And we really have to embrace that that's going to be critical to where we go. And in a digital age, we cannot ignore the human-centered nature of healthcare delivery. None of this is new. And in all of our discussions this week, as we've been talking about UHC, biosecurity, entity alleviation, or across the SDG agenda, all of those goals are achieved by investing in a healthcare workforce. So Seed Global Health is very committed to supporting these commitments, and we feel incredibly honored to hear these discussions and look forward to carrying this premise forward. So thank you.
Okay, so we've got, just so that we make sure that today doesn't just end at today, of course, you know, we're being live streamed. I'm sure people are tweeting about this. You know, add the appropriate hashtag, maybe hashtag health workforce, and, you know, tag at WHO so that we, you know, Peter's team can actually follow up. And the focal point here, sitting right here, is Sonali Reddy. So if you want to give her more work, she's absolutely here in the middle. Sonali, raise your hand. There she is. She'll be able to collate some of the ideas, these excellent ideas that we're having. We've got the gentleman in the white shirt, followed by the delegate in the grey suit. We'll go first to the back.
Hi, my name is Vince Chadwick. I'm with DevEx. I'm a journalist, so I guess I'm neither a peer nor an ally. But my question is for Peter. Sorry, g'day. I wanted to go back to your remark that the market will fail us if we let it. And I see on the board here we've got to implement what works. So I guess my question is, in your experience, what works when we talk about not letting the market fail us? And if you could speak to specific country examples, that would be great.
So I think, Peter, we can put that together at the end. I mean, these is really just about creating a basket of ideas first, but we'll get to that. Then we'll go over here. So we've got the regional director of EMRO.
Yeah, thank you very much, James, for leading this discussion. Just I'd like to share, to save your time, a few ideas, about our real situation in EMRO. As you all know, EMRO is facing a lot of challenges, and most of that challenge is related to the man-made disasters we are facing in most of the countries. We have, a resurgence of communicable diseases. We have high prevalence rates of deaths, morbidities, mortalities, relevant to the non-communicable diseases. In addition to that, we have, destruction of most of the healthcare facilities in countries that are passing through crises, man-made crises and conflicts and wars. Now, focusing on the issue we are discussing now, I'd like just to share with you a few challenges that are there in our countries, in member states. One of the challenges, is shortage of production of healthcare professionals at all levels. Yes, some countries, they have made plans to produce more healthcare professionals, but still it is really lacking. And adding to that is, the citizens working in healthcare system in these countries are leaving their countries because of the conflict, because of the emergencies, leaving their healthcare system really suffering from the shortage of staff. The other challenge is the skill mix, and I'm sure this is really a global problem, not only in EMRO. We have a production of a high number of nurses, for example, in some countries, while they are suffering from shortage of doctors, shortage of pharmacists, shortage of other healthcare professionals. So the skill mix imbalance is a huge challenge that is facing at global and regional level. The other problem we are facing in countries now, especially those which are suffering from crisis, which ultimately are suffering from financial problems, is the low employment level. We have graduates without employment. Some of them, they manage to go out, but others are staying at home doing nothing. This will send a very strong message to people that, a healthcare system is no more absorbing for employment. So the secondary school graduates definitely will not go to the healthcare system. This is, in the long run, is adding to the problem in those countries facing financial problems. There is one minimal risk, talking about artificial intelligence. Nowadays, we hear about robots doing surgeries. I'm sure they will not replace us, but in the long run, this artificial intelligence is taking over the human power, to work. This is something that we need to focus at. Last but not, I don't want to, is giving women, the empowering and engaging women in providing healthcare services and involving them, participating them in providing healthcare services. In some countries, like for example, in Oman, for example, we have the nursing cadre is composing, the nationals is composing maybe 80 or 90% of the staff, and the majority of them are female, women working the nursing side. Some other countries, they are facing difficulties in recruiting female nurses because, most of the graduates are male. So we need to look at the gender also balance when it comes into the healthcare services. Thank you for that, and I'm sorry if I took long.
No, but Dr. Al-Madami, I mean, all regions in the world are important, but I remember a couple of years ago we moderated the emergency response meeting with Peter when he was leading that, and hearing the staggering number that I think well over half of your countries are in constant emergency mode. I'm sure that you're doing the best that you can do, but of the workers that you are able to have there, and I remember these extraordinary, because they came out onto the floor in the executive boardroom and they were giving these testimonies about their personal stories. I mean, they're individuals with huge pressures on them every single day when they go to work. going to work is already a challenge in itself. Do you think that of the workers that you do have, and you may say that certainly not enough, but of the workers you do have there, are they supported enough as people?
It varies from one country to another, but in general, overall, I can say, yes, they are supported first by their families. They are supported by the community members, supported by healthcare leaders. But as I said, they are facing the difficulty of getting employed, and if they are employed, they are low paid. So this is putting a lot of pressure on it. Adding to that, shortage of staff is putting those who are in the system working for long hours, and under huge pressure. So putting them under psychological stress.
Because we've been talking about quality as well, that we're expecting them to work under these conditions, how they expected to create quality work day after day after day. I think we've got one more comment over here, and please just know that this isn't such a traditional format today, so we're going to go back to the panelists and back into you, so this is not your last chance to speak. Please.
Jabi with Last Mile Health. I'm a physician. My comment's really actually a question. We spend a lot of our time when we speak about support for health workers considering it as a technical challenge, and that it is. But it is also a challenge, and I think many in this room acknowledge that, about power and power imbalances. Some of those exist within our own professions. We have to sometimes break our own guild mentality to allow the redistribution of tasks, for instance, to other workers. But there are also power challenges outside of our professions. And so this is one of the lessons we've learned having worked with Madam President in Liberia during and before and after the Ebola epidemic. But she was clear as a politician that this had to do as much with policy as it did with politics. And so she is now leading a new center focused on training the next generation of women political leaders on the continent. And I wondered if Madam President could comment on the role of power and politics in solving this 18 million health worker shortfall.
Madam President, do you want to comment on that now or towards later? Because
later.
Okay. Are you happy with how this is going? Okay. I won't wait for an answer. I feel a bit nervous, actually. I'll just keep going. In that case, please, to the delegate here with the computer.
Okay, thank you very much. My name is Amanda Banda. I'm representing the Health Workers for All Coalition. It's a grouping of civil society organizations globally and health workers who are working on addressing the same issues through advocacy. And two things I just want to highlight, I think, just repeat one of them, I think is, Dr. Kalin, you mentioned this, the ability to retain and really keep the health professionals that are joining the health workforce, I think, is critical. This is not being adequately addressed in a lot of countries. We recruit, but we lose a lot of them for the number of reasons that have been highlighted in this. We have brilliant policies in a lot of governments that are not being implemented. That takes me to the issue of investment, and it's a brilliant, I like Norway's commitment and initiative, and I think with your excellency coming on board, I wonder then how do we get a lot more governments, and with you, Norway, I think it's also a question to you to find out how are you engaging other governments in both the high income and the low income countries to emulate your example, and for your excellency, how are we going to really push this excellent example that has been set by Norway forward? Thank you.
Then I suppose I'll just ask Dr. Larsen about Norway, because Norway has innovated so much. Your relatively smaller population with this outsized weight in the development world and humanity. What would you have done differently looking back? If you could start it all over again and go back a couple of decades, what would you do differently to help ensure that it wouldn't be 18 million, it may be 10 million, it may be 1 million, it may be 0. What do you think you would have done differently so that we can learn from that?
Well, I wouldn't really suggest that Norway would have the solution on that question. If we had been able to, I think nearly all developed countries have underestimated the number of health workforce that they are at any time willing to employ. We are having health workforce analysts, and they are giving us projections all the time, and constantly we are underestimating the willingness to employ people in the health sector. I don't know any Western country that hasn't done that mistake, and one consequence of that is that health workforce find jobs in other communities with higher wages and where the society is also safe for their families and so on. So it's not strange that they actually tend to migrate. So, so I think we should have been better at that. The other thing I think we should have been better at is a word that you mentioned, the finance ministries. We haven't really been good at explaining that investing in health workforce is actually a very sound investment for any country. So, and we are actually working on that just now. That is the core of the work that the World Health Organization is doing together with the OECD and the ILO. That's the core of this UN high-level commission that gave the report last year, was led by France and South Africa, and they actually gave the arguments that ministries of health and ministries of education can take with them and go to the Ministry of Finance and says, these are the best economists the world have. They are showing the argument why this is a sound investment. So if you didn't know this report, it's a very important report. It's an argument that you can use discussing with your finance ministry. So it's important to find.
I don't know, do we have anyone from the Ministry of Finance over here? A Ministry of Finance? Because my question would be over here, would they even respond positively if the health and education ministries went to them? Would they open up their budgets? Would they be willing to work across? I suppose, Madam President, you know, being in all those different roles, may be able to reflect on that a little bit later. And also, I think, Madam President, you know, what the question there was, how do we anticipate and what could you provide us with a sense of what not only the next great health emergencies could be, but what are the next great global trends coming up that may impact our predictions for what the workforce should be in terms of quantity, but also in terms of quality, in terms of type, in terms of sectors as well. We are going to go to, thank you for that, Dr. Larson, but I also want to ask Musa Umaru again. We could talk about the Commission on the Future of Work. We could talk about the independent report, but I think we should also talk about a social dialogue. And where does that come in for you?
Merci beaucoup. C'est un point extrêmement important pour quelqu'un qui vient de l'OIT, parce que le dialogue social et le tripartisme sont au cœur de tout ce que nous faisons et de notre mode de gouvernance. Et justement, sur la question précise qui nous concerne aujourd'hui, qui est l'investissement dans les emplois dans le secteur de la santé, le dialogue social devient un outil et sera toujours un outil important pour pouvoir prendre en charge l'ensemble des préoccupations et des problèmes que le secteur connaît. Le personnel de santé est organisé selon les pays, selon les régions, en syndicats, en associations, soit des médecins, des sages-femmes, des pharmaciens, etc. Il est important donc que ceux qui sont les acteurs et qui sont organisés, les représentants de ces acteurs du secteur de la santé, puissent avoir voix au chapitre, qu'ils puissent discuter avec les employeurs, ceux qui représentent les employeurs, qu'ils puissent discuter d'un certain nombre de sujets qui sont des sujets actuels, que ce soit les conditions de travail, que ce soit la formation, puisque nous avons parlé ici qu'il est important de pouvoir adapter la formation et que ce soit une formation tout au long de la vie, que ce soit dans ce domaine, et voir là, par là aussi les développements de carrière, que ce soit la question d'égalité hommes-femmes qui se pose et qu'il faut pouvoir traiter là-dessus, tout ceci ne peut se faire qu'à travers un dialogue social fructueux. Vous savez mieux que moi, dans beaucoup de pays, le secteur de la santé, non seulement son importance, mais aussi les perturbations régulières qui interviennent dans ce secteur, qui font que le secteur ne donne pas tout son potentiel tout le temps, durant toute l'année. Donc, la seule solution pour pouvoir gérer de telles situations, que ce soit les situations présentes, que ce soit les situations conflictuelles ou les situations comment dirais-je, de gestion du futur, il est important d'avoir le dialogue social. Et ce dialogue social ne peut se faire qu'à travers les organisations de travailleurs et les organisations d'employeurs qui sont là, et l'État aussi, quand il est tripartite, parce que la place de l'État dans le secteur de la santé est importante, et il faut que l'État puisse, à un moment donné ou à un autre, pouvoir intervenir dans la question liée au dialogue social dans le secteur de la santé. Et justement, ce dialogue social, c'est lui qui permettra aussi, comme je l'ai entendu tout à l'heure dire ici, de voir comment on peut gérer le futur, comment on peut gérer l'avenir, notamment quand on parle de l'influence de la technologie, de l'intelligence artificielle. Ceci, on ne laisse pas la machine ou la technologie décider. Il faut que ce soit l'homme qui décide, et il faut que ce soit toujours l'homme qui soit au centre des choses qu'on fait, et c'est pour l'homme qu'on les fait. Voilà ce que je voudrais dire sur cette question, en sachant aussi, en rappelant que l'OMS et l'OIT sont deux organisations normatives. Donc la place des normes internationales du travail ou des normes de l'OMS, leur respect et les tentatives pour les mettre en œuvre, et ceci est essentiel. Voilà ce que je voudrais dire.
Thank you very much. I want to link that now back to Dr. Mata, who, you hold different roles. You're an infectious disease specialist currently at Washington University School of Medicine, but throughout your career, you've worked as part of and for the interests of youth, whether it be part of the junior doctors, whether it be now in your current role at Medical Students Association before, but also now at the Global Health Workforce Network as the Youth Hub Chair. You're surrounded here today in a unique position because 194 member states are here at this World Health Assembly, and some of them are here inside this room right now. What would you tell them or implore them in terms of government engagement to empower you so that they can help fill the gap that we're talking about? What's going to be the incentive, and what are some of the clever strategies perhaps that you could share with them and they with you in return if any of the member states want to respond to what Dr. Mata is going to say now?
Sure, thank you very much, James, for the question. So what I would tell you today for people representing governments here is I would actually urge you to include students, young professionals, young people in all aspects of health workforce planning, be it at the national, local level, but also within training institutions. And I'm not saying this as this tokenistic youth approach, let's have a young person sitting at every single table. Absolutely not. But young people can tell you what works, they can tell you what doesn't work. As far as healthcare workforce distribution, migration, career planning, causes for early attrition, etc., etc. They will tell you that coercive measures do not work. They will tell you that, for example, socially accountable education will work. Decent working conditions will work. Again, there's no one-size-fits-all. But engaging young people in this conversation, they will be actually able to tell you what are some of the projections as far as how to recruit and retain young people in the workforce. One last thing, talking to governments today and policymakers, I urge you to remember one thing, that young doctors, students, nurses, pharmacists, community health workers, they are people who are putting a lot of personal sacrifices, working long hours, days, nights, holidays, away from their families in order to keep yours safe. So I actually urge you today, and we as the Youth Hub, to include them in designing and investing in jobs that actually allow them to work in dignity for the future.
Do any of the member states want to comment on that? I mean, not necessarily as a member state, but to respond on whether those ideas work. I thought no one's going to put their hand up over here. Are you a member state? Oh, okay. Any of the member states first? No, they're very shy. Then we'll go first to the delegate. What, someone? Sorry, someone is? Nepal, please.
Thanks for all the panelists. What happened in deployment? We have 18 million health worker shortage. But if you will go to the disaggregate to the nations, like developing country, least developed country, we have very big problem. Not only problem, we are producing the health worker, but the retention is the problem. We are producing the health worker for developed world with the cost of least developed money. So how the developed world can compensate to the less developed country, those who are producing the health worker for the developed world. In Nepal, we produce about 4,000 health workers, medical graduates every year. But the retention is less than 1,000 per year. That is the problem. Thank you very much.
Does anybody want to respond to that directly, to that particular point, or wants to build on that point? If not, we'll go to the delegate here, please.
Thank you. My name is Aisha Al-Mahri, and I'm a delegate from the ICN. I was really hoping to hear 2 points, and maybe it's a kind of request from you as an expertise to really look into that challenge. Now, globally, we are really facing the financial risk and financial, challenges. And one of the things that recently we noticed, and I belong to these health organizations, where the message to us that go for the cost reduction and cost saving. I'm a nurse, and the first thing comes that go for the cost saving and cost reduction in the nursing workforce, because we are the major in any health organization. Lots of justification you are providing, and that's really will affect and will impair the patient's service and patient care. And really, I would like to hear something about it, because people will say, and we talk about the patient safety, there is we should not really cross the patient safety, but at the end, the money talks in these things. Second thing, about the youth and about really investing in the health workforce, I would really love to hear this, of creating a positive practice environment and a positive work environment. We will not talk about the physicians, but we are having a challenge to really retain and to recruit youth to join nursing and other allied health professionals, because these youth are looking into really what are the privilege, what are the really environment that the physician will have it, and what will be for the nurse. We have globally a good initiatives, like for example, Pathway to Excellence, Magnet Hospitals were really encouraging to build a kind of a positive practice environment for these for the healthcare professionals. One of the things that I'm facing personally, that encouraging the youth and the young students to come and to join this profession, because they go to the hospitals and they see how really the difference in the benefits, privileges are giving in the same organization and different health professionals. So I would really love to hear these things from you. So 2 things. The cost and the financial risk that's affecting in the workforce, and the second thing is about the positive practice environment, mainly targeting the nursing and the allied health. Thank you.
I believe I've got 2 over there, 2 over here. This is the last call, and then I need to save a bit of time for a couple of speakers who are going to wrap up some of the dots. So we'll go first to the gentleman in that.
May I just make a direct comment?
Please.
Yeah. So to the colleague here, absolutely. Number one, we talk about patient safety, but when we talk about decent working conditions, working hours, we all know what that means to patient safety. So when we're talking about cost saving and patient safety, this has to go through a decent work agenda. And the second question is, absolutely, we do not elevate one profession by pulling the other down. We need to elevate all professions together. We need to make an enabling environment where every healthcare professional and every healthcare worker can achieve their full potential in a very respectful environment. And I urge you again to also read our report and to come talk to us, because this is hopefully our agenda as a community of interprofessional organizations going forward. Thank you.
Sorry, could you just raise your hands if you do have an intervention to make still? I know I've got 1, 2, 3, 4, 5, 6, 7. Okay, you know what? I'm just going to take about 4, and I'm going to ask you to make them in less than 30 seconds. If it's not more than 60 seconds, I'm just going to move on to the next one. Because we have the button here. So the gentleman first in the blue blazer going to the white shirt. Less than 60 seconds, please.
Yes. My name is Pap Guy, and I'm with IntraHealth International. I wanted to ask the panel if they could address one issue, which is the situation of health and health workforce in conflict area. Unfortunately, we don't have enough health workers, so we cannot afford to lose one. But with the new tendency to attack health and health workers, we have a serious problem. And a subset of the problem that I would specifically like to address is the loss of credential during conflict area, where you have health workers who cannot practice and because they have lost their credential. So I hope we can give some thought on that, resolving that very serious problem. Finally, I'd like to ask Honorable, if you could also in your remark address how we can support your homologues in the countries, the leaders, really take on the battle and avoid politicizing the health workforce issue. I thank you.
Just one, please. And Peter will take the emergencies, and Madam President, if you would like to take that bit later, but just one, and we'll go to the blazer. Just one comment or question. The gentleman who was behind the one who just spoke.
Thank you. Good afternoon. Guillermo Mendoza from Pan American Health Organization. If any of the panelists can expand a little bit about the role, the stewardship role of the Ministries of Health in ensuring that the workforce responds to the needs of the population rather to the market. Thank you.
Thank you. We have the delegate here, please.
It's on. Good to go. Emma Stokes, President of the World Physiotherapy Organization. I'd like to come back to the point around power and politics, and I know that Madam President will deal with that. One plea that I would have is that any time power and politics and regulation get in the way of a health professional, such as physiotherapists, occupational therapists, being limited in their scope of practice, should be questioned. Because if all professionals, as Catherine mentioned, nurses, doctors, pharmacists, physiotherapists, the full workforce are enabled to work to their full scope, that is a solution to the workforce challenge.
Thank you. Sorry, you were going to applaud? You can applaud. It's okay. Here, and here. Yeah, very quickly.
Thank you, James. I'm Marcel Claquin from the Global Health Workforce Network Data Hub and the Technical Working Group lead for country and support. So, and my question is for Excellency President Sirleaf, Peter Salameh, and Dr. Omaru. It's about how we can support country to really access those public goods. And Dr. Larson talked about the Working for Health initiative. I've been working for many years supporting Ministry of Health, and especially in Mozambique. And well, first you have a language issue. Second, you don't have the perception and the understanding of the importance of those documents and how we can implement them with local evidence in country to make the case with Ministries of Finance. Thank you.
Thanks, James. I'll be very quick. Rupa Dutt from Women in Global Health, and also the chair of the Gender Equity Hub and the GWEN Network. So we released a report at CSW called Delivered by Women, Led by Men, a Gender Equity Analysis of the Global Health Workforce. There are several astonishing findings. I'm only going to highlight two because of the time. One, the gender pay gap in the health sector is higher than many other sectors. Particularly, it ranges from 26 to 29%. We also know that particularly in many countries, women do not have social protection protection. Women are not organized in trade unions. And I could go on and on about the gender inequities which are pervasive. My question is really for Madam President, but also for Norway as well, particularly what can we really do to have gender transformative policy action in country? How do we really make an investment case that not only is about investing in jobs, but also investing in an equitable manner across gender and broader intersectionality dimensions? And finally, really changing the narrative so that women and everybody else that's in the informal workforce are actually getting formal jobs. Thank you.
Actually, over at Rupert's event on Sunday, there was like a 10 ask flyer that went out on how you can retool that narrative. I don't know, it's probably on your website, isn't it? But if you want to, it's over there as well. I think we've got Thailand on one side. If you want to make your comment, Thailand.
Thank you very much. Health workers, without realizing their work value, is not sustained. What we have learned from Thailand is to integrate value within education training and within health system to achieve sustained USC, injecting value into their professions in education training and on-the-job training are key. What we should be invest is we need to invest on our energy in strategic way, in collaboration between education sectors and health system for integrating value along the journey of health workforce. Thank you.
Thank you very much, Thailand. What we're going to do now is Catherine's going to make one quick comment, and then we're going to go to reflections from Joseph Ghebreyesus, and then we'll have Pete Salameh. And if we could finish with the vision from Madam President to connect those dots. Catherine, please.
Thank you so much, James. So it's a personal set of reflections, colleagues, following Tuesday's dinner, just to draw things almost together. I was sat on a table with Bjorn, and we had health worker organisations, donors and national leaders there, and the issues of safe workplace and safety for our workers was key there. So it's come up today. James, you mentioned the absence of mental health in the discussions yesterday around health workforce and the health workers alongside our patients. But I've also heard today unifying issues of dignity and equity, not just for our patients, but for our health workforce, and of course the power and politics that goes on. So colleagues, thinking of next steps, drawing on what works, I've heard and I've seen that our youth hub and our gender hub are mobilisers, and they are places where conversations can start, and we need to action around a hub of sorts today. That's my proposal. We can mobilise the conversation, colleagues, but frankly, the conversation is not enough. We need measurable actions, real impact, inter and outer collaboration, James, as your challenge made very clear. And we need to work with education, regulators, employers, unions and patients. And if we do that together, that'll be a pretty good start. Thank you.
Great. So we are inviting now and introducing you to Dr. Joseph Ghebreyesus, who is the Director of Program Management at the World Health Organization Regional Office for Africa. Dr. Ghebreyesus, we wanted to position you towards the end to provide us with some of your thoughts on what you're feeling, what you're hearing, and what you're also learning amongst this group here in this room today.
Thank you very much, but I will make it in French. Je pense qu'avant tout, je voudrais reconnaître que je suis très honoré, fier de faire partie de ce panel pour discuter d'un sujet si essentiel. Dr Tedros, le DG, dans son introduction, a dit qu'il s'agit d'un sujet important et vital. Il est important rien qu'en regardant comment la salle est pleine et en observant également la qualité des panélistes et des débats. C'est vital parce que les besoins en matière de santé sont immenses et divers. Le directeur régional de EMRO l'a dit, et encore pire dans la région africaine. Les besoins sont immenses. Ce ne sont pas les bâtiments, ce ne sont pas les équipements qui vont résoudre ces problèmes. C'est le personnel de santé. Nous sommes là depuis quelques jours, nous parlons de couverture sanitaire universelle. C'est le premier message que je retiens. Nous n'allons pas l'atteindre. Nous n'allons pas l'atteindre si nous ne travaillons pas à résoudre le problème du personnel de santé. Et ça signifie quoi? C'est de prendre dès maintenant des décisions fortes et concrètes pour la formation, mais également pour le déploiement adéquat du personnel. Je travaille en Afrique, je connais des centres de santé où des infirmiers dans la capitale travaillent un jour sur 3. Et dans certaines zones isolées, vous n'avez personne. Ils doivent marcher 15 à 20 km pour avoir des soins. Donc, le premier message, ne rêvons pas de couverture sanitaire universelle si nous ne prenons pas à bras le corps la problématique du personnel de santé. Le deuxième message que j'ai retenu, c'est qu'il y a un défi. Le défi est grand. 2030, c'est à notre porte, c'est très bientôt. 18 millions de travailleurs, c'est immense. Mais j'ai également entendu ce message d'optimisme qui nous dit que ce n'est pas insurmontable. C'est possible. Alors, il faut investir. Investir dans le personnel de santé, ça nécessite un leadership politique fort et une action intersectorielle efficace et durable. Au-dessus du ministre de la Santé, il faut on implique le ministre des Finances, le Parlement, les autres ministères en charge de l'enseignement. Et ne pas voir cet investissement en termes de coûts, mais en termes de retour sur investissement. Et j'ai aimé ce terme, on a parlé, Madame la Présidente a parlé d'effet multiplicateur. On a parlé des retours d'investissement pour un secteur porteur de croissance économique. Et c'est là que c'est important. C'est là que nous devons voir l'investissement dans le personnel de santé, mais ne pas avoir seulement de l'argent que nous mettons sans rien voir au début. Aujourd'hui, nous avons des millions de jeunes et de femmes qui chôment. Le secteur de la santé doit se positionner pour absorber ces jeunes qui sont capables de travailler pour la croissance économique inclusive des pays. Ces jeunes ne cherchent qu'à travailler et la santé peut jouer ce rôle-là. Seulement, nous devons sûrement adapter notre message. Parler au ministre des Finances, parler aux députés nécessite une adaptation des messages que nous transmettons, mais également produire des données probantes qui puissent convaincre qu'il faut investir dans le personnel de santé. L'avant-dernier point, je ne sais pas comment le formuler, nous avons parlé d'humanisation et d'équité en matière de personnel de santé. Les jeunes, la parité genre, les salaires, je crois que c'est l'égalité en matière de salaire. Nous avons parlé de la rétention du personnel. Nous avons parlé de la compensation. J'ai beaucoup aimé également cette idée des pays qui absorbent par rapport aux pays qui produisent, l'amélioration des conditions de travail, la sécurité du personnel et la nécessité de promouvoir le dialogue public. Autant de problèmes, je pense, que nous pouvons gérer. C'est pour cela que l'OMS a justement lancé cette campagne. Cette campagne que nous appelons « Appel à l'action » pour catalyser les engagements des organisations de travailleurs de la santé, y compris les associations professionnelles, qu'elles soient des jeunes, des femmes, toutes professions confondues. J'ai vu qu'il y a les jeunes étudiants qui également cherchent à travailler, les syndicats, afin de remédier à ce problème de déficit de 18 millions d'agents de santé. Je vais juste m'arrêter pour là. Walk our talk. Il est temps maintenant d'agir. 2030, c'est bientôt. Nous avons suffisamment d'informations, suffisamment d'éléments pour convaincre qui que ce soit. Il reste une seule chose, c'est de passer à l'action. Et je vous remercie.
Dr. Ghebreyesus, you brought a lot of clarity to the many different strands of thoughts that were expressed in this room, and I'm very happy that all of you contributed to that very inclusive discussion. There was that question, though, in emergencies, Peter, and also there was a question on failing markets. How do you address that as well, amongst others?
Thanks so much, James. I want to focus on what we do moving forward based on good country examples of what works. So I'll be brief. We can give many examples, and I'm happy to meet with you bilaterally, but let me just choose a few. One is from the Working for Health program on the country of Niger. That's a program funded mainly by Norway, and we need to give credit where it's due. And it's a program of WHO, ILO, and OECD. Many examples, Niger, Guinea, and others, but let me focus on Niger, where WHO and ILO developed a national intersectoral health workforce investment plan. With a catalytic funding of only $400,000, that plan was developed with a focus on one of the most underserved areas, Diffa region in Niger. The ultimate result was an additionality of more than 12,000 health and social sector workers with increased access to basic health services for 1.8 million people in some of the most isolated rural areas. There were also additionalities, externalities there that were positive, the development of community-based health insurance programs and M-health programs, and ultimately it attracted an investment of more than $25 million in the workforce. I can give you several examples afterwards if you like. Let me switch to the emergency areas. Well, I have from my own experience many examples. We don't have time to go into it, but I'll summarize one of them. Zimbabwe in 2009, you may remember, had the worst cholera outbreak in the history of Southern Africa. And at the time, there were billions of percentage hyperinflation. The Zimbabwe dollar crashed to becoming basically worthless. Health workers were not being paid, and there was a massive out-migration of Zimbabwean doctors and nurses, first to South Africa, but then to the UK, Australia, many other places. The UN, I was there at the time for UNICEF, developed a program with donors called the Zimbabwe Transition Fund. One element of that was to pay the salaries. Zimbabwe was under sanctions and couldn't receive money from the donor community. To pay the salaries of health workers to stem the out-migration and to bring health workers back. It was an extremely successful program, attracted many hundreds of doctors and nurses back from South Africa to staff the Zimbabwean new health sector programs. Can give you further details on that. The question on accreditation is a really good one. One of the best programs I've seen recently is for Syrian refugees in Turkey. It's a WHO-supported program. The problem that you've raised is very significant. So, of course, Syrian doctors, and there's many thousands who've gone to Lebanon, Jordan, and Turkey, are not registered, and they can't get their qualifications recognized in surrounding countries. We managed to broker a compromise, the UN, WHO, donors such as the EU, with the Turkish government, whereby the Syrian physicians and nurses would not have a general registration for the Turkish population, but they would be accredited to work with the Syrian refugee population. It's been an extremely successful program. It's served a huge purpose because the Syrian refugees now have access to people that speak their own language, highly qualified and trusted by the Syrian population. It's been written up, and we can give you more details on that, but it's a great example of what we should be doing much more of. I'll end with a comment on decent work, and perhaps ask the advocates, because I can see there's some very effective ones in this room, and point them in perhaps a slightly different direction. Not to say that what you've been advocating for is not important, but I'm going to add to your workload. And it's advocacy around two specific examples. One is around occupational health, if you like. When we think about all of the recent Ebola outbreaks, the first and a very significant set of people who are affected are healthcare workers. And having spent a lot of time in the Kivus in the last few years and in DRC in general, it's shocking to see that there isn't basic personal protective equipment. There isn't a clean needle, let's be honest, in the majority of health facilities in the Kivus. And while health workers have to face those sort of risks, you really wonder what we're talking about under the label of decent work. So let's think about that aspect for the most underserved countries. The other thing I'd like to point you towards is a program that WHO has developed in recent years. One of the founders of this is in the room, I think Erin Kenny. It's a program looking at attacks on health workers. And you mentioned it in your question. It's becoming an increasing problem, particularly in the Middle East, but also in other parts of the world, where health workers are being targeted simply because of what they do. We've had our own colleague murdered in DRC, as you know, only a few weeks ago, doing his job in that country fighting Ebola. Many polio workers in the Emra region. And certainly it's something that we're now tracking with support from several donors. You can follow on #NotATarget and our website. We need global advocacy on this issue. It is an issue of safety and dignity of health workers, and it should be something that in this space we advocate for, because sometimes the dramatic examples are the tip of the iceberg and they help to really show what the iceberg looks like. Thank you.
Thank you very much, Peter. While all of you have been discussing, I was taking a quick scan through Twitter to see what people are saying. And Mark Britnell, who is the Global Chairman and Senior Partner for Health, Government and Infrastructure at KPMG, put out 2 tweets that stood out. He says, we're facing a global workforce crisis in health. We should educate and train more clinical professionals for the UK and across the world, which comes back to your point. He also said we can help countries deliver universal healthcare, leverage our power, improve British productivity beyond Brexit, and increase national wealth. And I think that was captured in an op-ed that he wrote. He doesn't have, there's an image of it. It doesn't say which newspaper it is, but I think from the font it looks like the Daily Telegraph. And then he also adds one more, posted a couple of days before that. He says, in Beijing, the Chinese government has announced a target to increase the number of GPs from the current level of 209,000 to more than 700,000 by 2030. It's a question of political will and social cohesion, coupled with a desire to reduce doctor burnout, which is a growing worldwide concern. Madam President, you've heard what everybody has said. You wanted to hear what everybody had said. May we give you the floor to close today and to collect all these thoughts as we move forward from here.
Very well, thank you. Let me start with what Raj came up with about policies, politics, and power. One has to be assured that policies have a clear roadmap for the implementation of goals. Whether that goal is universal health coverage, maternal mortality, in child mortality, reduction in the level of incidences, whether it's malaria or HIV or whatever. But those policies have to be clear about that, and those policies that are also consistent and in sync with overall national goals and the national vision. Politics is, good politics would mean a buy-in for all the approaches toward the achievement of those goals. And that takes a lot of communication, knowledge, training, so that people get the message, what those policies will result in, how will this lead to better health, to a better nation, and to people's own participation and benefits. So one has to be clear about that. Power, women don't always talk about power, we talk about leadership. And the leadership mean is to use that to be able to get the coordination that's required when you're moving across sectors. Health, ensuring the finance ministry, the education ministry, all that have a part to play, are coming together toward a common goal, because that common goal also helps you to achieve an overall national goal. And so I think that plays a big part in being able, and if one uses that leadership, call it power, for designation in such a way, and delegation of that authority to those who have responsibility for the formulation of the approaches and the implementation of the goals, then I think you're more assured that you'll be able to achieve your objective. When it comes to some global trends, clearly one is concerned that there have been a lot of resistance in some cases, in cases like malaria, where insecticides and bed nets and all have been used, or resistance by mosquitoes is something that ought to be addressed, to find new ways to be able to have a much more effective response, more effective to achieve, because we've set for the End Malaria Council, the goal is to end malaria completely by 2030, but the trend right now would be, unless we can find something new, maybe some of the pharmaceutical companies will be able to help with this, and others, to see how we can achieve that. The attack on health workers, I think to a large extent, it's a question of communicating, building a relationship with the communities in which the health workers serve. Because many times the communities do not understand, particularly if you're facing a pandemic like Ebola, where there's fear, and people in the communities do not understand the fear and the effect, and all they know is protecting themselves. Then they tend to take it out on anybody who they think may be doing something that may not bring them the relief, but may add to a spreading or a more endangering of themselves. And unless we can get that kind of communication in communities, and that's why we talk about the community health workers. When a community health workers composed of community leaders and community residents themselves are out there in the health sector providing service, then they have an understanding, because they have the same tradition, they have the same culture in the community, and if they're not from those particular communities or ethnic groups, they learn quickly to be a part of it through adaptation of the same kinds of rules. And so that, I think, will lessen it, aside from the proper criteria and all that they have to carry. But I think that communication is something. And coming back to global trends, we're concerned about development official assistance and what's happening in this now increasingly complex global environment, where the mobilization of resources to be able to achieve these goals, whether it's trying to fill the gap of the 18 million health workers that we now face, or whether it's to ensure there's continuing resources for the different funds that provide the means for the for the treatment, that provide the means for training, provide the means for being able to invest in the human capital that's necessary. If we don't find a way, not that there's not the money and capital out there, but just that the willingness now to be able to ensure that it reaches the intent, is something that we need much more advocacy on by healthcare associations, by all the groups that are involved in ensuring that we do try. By the 2030, the Sustainable Development Goals, a large portion of it need to be met. We cannot have it fall back like we did with the MDGs. Sustainable Development Goals have a great potential to make it a better world.
Madam President, thank you very much for collecting those thoughts, for showing us what is possible, and also for framing that on what we can anticipate next and how we can best prepare ourselves now for that. Our next technical briefing will be in the same room at 12:30 tomorrow. This has been the most interactive with the greatest delegate input, so we really thank you for that, and all of our panelists for being here. But I think it's most appropriate for all of you to join me in thanking President Johnson Sirleaf again, who in the most dire and desperate of circumstances has shown the world that there's always evidence for hope and success and transformation.